together. No matter when you know, no matter what is your pulse, there's way to go for a something to all the people around the world. Sharing your experience and make the whole world smile by your kindness and talentness. Sharing your commitment to help the whole world smile by your passion and intention. Lend us a hand. No matter who you are, no matter where you come from, there's no big deal for us walking forward together. No matter when you know, no matter what is your pulse, there's way to go for us something to all the people around the world. Sharing your experience and make the whole world smile by your kindness and talentness. Sharing your commitment to help the whole world smile by your passion and intention. Lend us a hand. The whole world smile by your kindness and talentness. Sharing your commitment to help the whole world smile by your passion and intention. Sharing your experience and make the whole world smile by your kindness and talentness. Sharing your commitment to help the whole world smile by your passion and intention. Sharing your experience and make the whole world smile by your kindness and talentness. Sharing your commitment to help the whole world smile by your passion and intention. Lend us a hand. By your passion and intention, lend us a hand. Come to join with us, ICD, give us your hands.
Good evening, everybody. Welcome to our ICD monthly webinar. And tonight we have a very interesting topic. So to start off the webinar, I will call upon our moderator for tonight's session, Dr. Nagam. She will moderate the session for our speaker tonight. Dr. Nagam, it's all yours.
Hi, good evening. Hello, can you hear me?
Yeah, we can hear.
Yes.
Okay. Good evening to thank you, Dr. Prof, for your invitation as moderator for this evening, and I want to welcome all of the participants for us in this webinar tonight. Another Wednesday of knowledge where we are having another expert sharing their expertise with us. Our speaker this evening is my dear friend and colleague, Dr. Nawwal Alwani Muhammad Razi. Dr. Nawwal will share with us today a topic that is very important, both for the specialist and for the dental practitioner, for the academician and for doctors working in the communities. But before that, let me introduce Dr. Nawwal to you. Dr. Nawwal graduated in 2008 She received her master's in dental public health from the University of Sheffield in 2013. In the same year, she obtained diploma in dental public health from Royal College of Surgeons of England. She served in the Ministry of Health for 3 years, and then she joined academia in 2011. Currently, she's a senior lecturer in the Center of Population Oral Health and Clinical Prevention Studies in Faculty of Dentistry, UITM, Malaysia. She's also currently a PhD student in the Faculty of Dentistry, University Malaya. Her doctoral thesis was on school-based smoking cessation programs for adolescents. For tonight, Dr. Nawwal will be sharing with us her expertise on the title of Bridging Oral Health Disparities Through Local Community Program. Dr. Nawwal, the screen is yours.
All right. Thank you, Associate Professor Dr. Nagam. Give me a few seconds. Okay, I hope everyone can see my slide.
Yes, Doctor.
Okay, all right. Okay, thank you again. Thank you to Professor Datuk Muhammad Ibrahim Abu Hassan and Associate Professor Dr. Nagam for moderating this session. Assalamualaikum and good evening, everyone. I am Nawwal from the Faculty of Dentistry, University Technology Mara UiTM, Malaysia. So once again, thank you to the International College of Dentists, Section 15, for the opportunity for me to share a short webinars tonight. Hopefully this session will be a light one, a refresher course of some sort regarding the issues on oral health disparities and sharing session of some of the local community programs that have been conducted in our faculty. So without further delay, let us proceed with the session entitled Bridging Oral Health Disparities Through Local Community Program. Okay, wait. Okay, so before I begin, welcome to the Faculty of Dentistry here in Sungai Buloh, Selangor, Malaysia. For those of you who have not had the opportunity to visit us here, we have been around for the past 17 years and with over 120 academic staffs and over 500 current undergraduates and postgraduate students, the faculty aims to produce competent graduates to provide the nation with much needed human resources in the field of dentistry. So as an introduction, health disparities refers to the differences in health outcomes between different population groups. So as an introduction, this difference can be health disparities. Difference can be based on factors such as age, ethnicity, socioeconomic status, geographic location, gender, and other social determinants of health. Similarly, oral health disparities is reflected through a disproportionate prevalence of oral disease such as dental caries, periodontal diseases, or cancers on a particular population. So according to Northridge et al., disparities in oral health care means unequal opportunity for the population to be healthy. And this could be in terms of either access to care or the opportunity to practice a healthy behavior. Thus, as a dental professionals, it is important for us to be aware of these disparities and figure out ways to reduce the gap by providing the disadvantaged population the opportunity to be healthy. So again, according to the CDC, health disparities are essentially preventable differences in prevalence of disease, injury, etc., and differences in the opportunity to be healthy faced by a certain section of a population. So to give another idea of how health disparity works, even in the developed countries such as the UK, the least affluent or the poorer population in England live a shorter life, 19 years to be exact, having multiple chronic diseases 15 years earlier, having spending more years in sickness and dying sooner than the rich population. So this slide shows the suggestion by the CDC regarding the causes of health disparities. Although the cause of health disparities is multifactorial, the main causes that were highlighted will, of course, poverty, inadequate access to healthcare, individual and behavioral factors, and inequalities in education. So from the oral health perspective, in a 2021 review conducted by Bastani et al., similar factors were identify with additional factors such as health status and environmental factors, which include social, economic, cultural, and additionally factor related to the availability of and affordable health services, and also the oral health personnel's knowledge were some of the identified contributing factor that perpetuate this oral health disparities. So brief information from the Malaysian National Health and Morbidity Survey conducted in 2019 on the nationally representative sample. It revealed that the state of Sarawak in West Malaysia has the highest prevalence of reported oral health. Furthermore, rural population reported more health problem than their urban counterparts, and gender-wise, the female reported more oral health problems than males. So the Malaysian government have made various efforts to improve community oral health care. And one of the key initiatives in the National Oral Health Strategic Plan for the year 2022 to 2030, which aims at reducing the oral health disparities across the country and improving the population's oral health status and quality of life of the population. So the program ranging from the fluoridation of water supply, targeted community program of professionally applied fluoride, nationwide oral cancer preventive program, and community outreach program. So other sectors such as Ministry of Defense and the Ministry of Rural Development also were involved in providing dental care to the population, and of course the private dental sectors and the NGOs. So this slide shows the value of empowering community, or why it is still relevant to plan a community program. So in general, firstly, of course, it would improve the oral health outcomes by transferring the knowledge and skills to the community. Secondly, it's also increase access to care by tailoring to the specific needs of the population. And most importantly, of course, it is a cost-effective and a sustainable choice. So in community program, the dentists who enter the community need to adapt the dental system that he or she bring to the community's environment. So conclude in a nutshell, public health programs that did not match the local conditions are basically meaningless, because input by locals is very fundamental, and engaging with the community will ensure the sustainability of your community program. So according to Rena et al., these are a few suggestions that of what could be an effective oral health program across different age groups in the community. So for children and adolescents, we can consider programs such as fluoride, toothpaste for preschools, oral health promotion, utilizing motivational interviewing. And for older people in the care facilities, nurse-led training and oral health educations to the entire nursing care community could be considered. And for pregnant mothers and infants, they will always benefit from programs that empower their skills and increase their confidence in their oral self-care. So this slide shows the practical difference between the clinical preventive approach and the public health preventive approach. So walk-in patients and community are two different types of audience in terms of their health-seeking behavior. So as a dentist, we need to understand this. You need to be aware that patient that comes to you have already established a certain social advantages or social capital for them to be able to leave their work or their child in order to seek treatment from you. Okay, so this would not be the case in the community that you plan to go to. So these differences will dictate the approach that you need to use in your community program. So essentially, public health preventive approach will always focus on seeking to achieve sustainable health improvement, aiming to reduce health inequalities, addressing underlying causes of disease in society by tackling the social determinants. We almost always focus on common risk factor approach, which ultimately facilitates self-care and definitely works in partnerships with other agencies and utilizing evidence-based in designing and evaluating your intended community program. So according to Prof. Brickhouse from the Virginia Commonwealth University, these are 5 ways dentists or dental professionals can help to bridge the gap in oral health disparities. First, of course, by focusing on prevention and sustainable health behavior of your patients and their loved one by supporting the community oral health education. Second, help the marginalized children and their parents to access dental care. And this also could be done through outreach programs or even teledentistry. Another one is you could provide your time to visit classroom or daycare to teach children and parents about oral self-care. So furthermore, you can also share opinions and support the group that influence policy for better oral health. And finally, chair side wise, you can also always walk through your patient's oral health problem and help identifying solution that can make a difference instead of just a very curative methods of communicating with your patients. You can also remind them that it is preventable and how your individual patients can change the oral health of his, nucleus family. Okay. So according to the guideline from the American Association for Community Dental Program, here are the 6 ways for developing and enhancing community oral health program. Of course, number 1 is mobilize community support. It is always helpful to liaise with groups in community that may have an extensive oral health needs, such as child program, schools, community action agency, cultural and linguistic minority program, or even faith-based organization. So second is assess needs and resources, which mean utilizing evidence-based understanding of the community current health needs. Third is determine priorities and plan the program. Fourth, the implementation of the program. Fifth is to evaluate the program. And sixth is, to me, is another step that can further enhance your community program is, of course, participating in policy development effort, okay, which includes also disseminating the findings of your community program. So in the following slide, I will share several local community programs conducted in this faculty, in the UiTM Faculty of Dentistry. So the local community programs that were conducted in recent years involve generally the participation of preschoolers, primary schools, the Aborigine or Orang Asli, and the local community. So Oral Health Carnival in 2018, before the pandemic, was part of the academic requirement for the Year 4 dental undergraduates to conduct a community program. With the advice from the lecturers, the students were trained, were guided to write a working paper with a proposal of the entire program. So this usually planned 6 months or a year ahead of time. So the program required the adaptation of the important stages in planning cycle, which is basically assessment of need, identifying problems, developing aims and objectives, assessing available resources, implementation of the program, and finally evaluation. So the second Oral Health Carnival with the Safari team was conducted in the next year. So similar with previous year, assessment of need required. This assessment of need required the student and lecturer to conduct a need assessment through several meetings with the school's teacher to assess what are the resources needed and what are the appropriate program to the audience. So in both series of the carnival, the aim is to increase confidence and increase and engaging the participant. So thus role-playing activities is a must. Role-playing means the preschooler have the opportunity to become a dentist, while storytelling, puppet show, singing and coloring competition with oral health teams were planned. So the mascot will also prove to be a valuable addition in order to gain the preschoolers' interest. So in some cases, our faculty were invited to a particular establishment, such as a privately owned kindergarten. So again, in this case, needs assessment need to be done in order the program to be fully beneficial. With the participation of our postgraduate students who were a practicing dentist, they conduct a dental examination and fun activities such as storytelling with a busy book, role-playing activities definitely, and the coronation of King and Queen of Bright Smiles. So in activities that involve dental examination, particularly on children, important steps such as documentation of parental consent and referral pathway should always be planned and explicitly described in the working paper or the proposal. Next is Oral Health School Project organized by the Year 4 undergraduates. So this is the first program conducted with the COVID-19 restriction in June 2022. So similar steps of identifying important stakeholders and resources were done. So in the program that involved a large group of school children within the wide school compound, additional concerns such as risk assessment in any foreseeable emergency situation need to be sorted within the team and the school prior to the program. So a certain aspect of program were also evaluated from both perspective of the school children and the teacher. So our faculty also sometimes was invited by neighboring schools to provide toothbrushing drills to the first graders. So similarly, to avoid unnecessary waste of human resources and materials, discussion of the school is necessary, taking into the consideration the parental permission, the documented parental permission, the running of the teaching and learning session, and the logistic of the activities in ensuring the program is safe and comfortable for the school children. Okay, next is oral health program in the state of Pahang. With the Aboriginal communities require the team to think anthropologically, which means the students need to understand the culture, social structures, and their belief system. Because none of the team were of the Orang Asli origin, care should be taken in ensuring the appropriateness of the program. So this is done by conducting several meetings prior to the main program with the Tok Batin or the leader of the tribe to ensure the program were well received by the local communities. Finally, the most recent program was a home visit to the Orang Asli community in the state of Johor as part of an upcoming community program with a larger audience in the same locality. So as the program was organized by the postgraduate students, having an introductory activities ahead of the main event was beneficial to both parties. So for the team, it will build a better rapport with the community and prevent the unnecessary troubleshooting that will be cost saving both in monies and human resource. It also can provide a bigger crowd as it can build the anticipation among the community. So in terms of evaluation, it also provides a meaningful and measurable outcome of the program effectiveness that can be part of an ongoing translational research. So, all right, next, a little insight on inclusion of oral health care in clinical practice. So social exclusion can have a significant impact on healthcare. So according to Freeman et al., social exclusion is partly caused by the concept of othering between the dentist and the patient. This include making judgment, isolating and misunderstanding the patient's current health conditions or choices. For example, the patient is being criticized by dentists for neglecting their oral health, missing appointment, or HIV patients being judged by their quote unquote chaotic lifestyle. So finally, before we end the session, I would like to emphasize on the additional consideration in planning for community program to avoid the program from being too prescriptive and end up to be unsustainable by the local communities. The dentist should consider again the health literacy of the targeted populations and their cultural appropriateness of the intended program. So health literacy is the ability to obtain, to read, to understand and use the health-related information in order for them to make appropriate health decision. So be very particular about the kind of material that you wish to bring to your intended community, so that it won't offend any part of community. So that is only can be done by, a few visit or a few discussion with the local leader. Okay, so that would be my the last slide for my session, my very short session. So I would like to take the opportunity to invite all of you to participate in the 5th and upcoming IDENTEX that will be held in June. So please visit the website for more info. And our second program, which is SMILE 3.0, which is organized by our dental public health postgraduate student, will be held for the first time in both physical and virtual platforms. So kindly scan the QR code for more info. The community program will be held in Johor, and there will be 5 webinars for the publics and professionals to participate. So here are my reference. And with that, I thank you for your kind attention.
Thank you so much, Dr. Nawwal, for the very interesting presentation. And your topic resonates a lot with the mission of the ICD, which is community service. So thank you. We enjoyed and benefited from your expertise. Thank you so much. Now I would like to invite all our participants to if they want to discuss or ask any questions from Dr. Nawwal, you can write your question in the chat section or in the Q&A. I think we have one question in the Q&A. It's a greeting for you from Prof. Arshad. Thank you, Prof. Arshad.
Dr. Nagam, can I ask a question to Dr. Nawwal? Yeah.
Thank you, Prof.
Thank you for a very interesting presentation just now, Dr. Nawwal. At the initial part of your presentation, you did mention about male having less complaint or something to female. Is it because male doesn't complain more or more tolerance to pain than female? Or this is a real discovery finding from survey or
Prof,
from
thank you, Prof. Datuk, for your inquiries. So I just chose this because this is the most recent self-reported survey. Yes, Prof, it's 2019. It is self-reported. From face value, we can't really tell the reason why. But I suppose, yeah, it would be dependent on the way they cope with the pain. And perhaps sometimes, I think maybe the threshold of pain or the way they might think, seeking dental treatment is maybe such a hassle that they decided they are free without oral health problem, despite maybe perhaps feel the pain of the oral health. That is completely speculation from the cross-sectional.
Okay, thank you. I don't know, is there any other question? If not, I got another question.
Yes, Prof. Datuk, let's.
In carrying out these CSR activities, what are usually obstacles faced by the organizer in carry out this? We have to go out to the community. So, what are the most obstacles that we find, your community team find from organizing this?
Thank you, Prof. First of all, to give context, we are ultimately a teaching institution, yes, Prof. So our community service program will be not going to be entirely throughout the year. So finding a ideal time of planning to go to a specific population would be a difficult things. Despite the full support from the faculty, I think the timing usually and the logistic of it let's say if we plan to provide the whole mobile dental clinic, that might not be entirely feasible. So we need a smaller instrument which require more human resources. So yeah, balancing that between that and operating a proper faculty of dentistry, that would be just it. Otherwise, we always have the support from the faculty. If it's feasible, we are allowed to go to any community, provided we have the times and the human resources, bro.
What about financially or the local authorities in implementing this program?
Part of the working proposal, usually we include the skills for the students to find a sponsorship in order to reimburse the community. So to the best of our ability, we try to find extra funding to make the program more valuable and to be, to provide a token of appreciation to the participant. Yes, again, the faculty support also make a difference. But yeah, finance is always a challenge, because when it comes to prevention, as compared to the curative, definitely the allocation usually went to the curative sector.
Maybe you can try to work with the NGO for some.
Yes. Yes, Prof, definitely. So part of our upcoming program also will be having involvement from various sectors, including the NGOs.
All right, thank you. I think you got another question in the Q&A box, Dr. Nagam. Okay.
Yes, Prof, we have other questions. So, Dr. Nawwal, there is one question from anonymous attendee. Dear Dr. Nawwal, thank you for the superb presentation. I have few questions here. Could digitalization nowadays create health disparities or widen the gap? In what ways will digital improve the health inequalities or inequities?
Okay, thank you for the questions or your information. Yes, in a way, digitalization can work both ways. But of course, the fact that easily over 50% of the population, or nearly 70%, have already had smartphone. So, but that is specific to a certain age cohort. So we should take that as a window of opportunity to get to that cohort. But of course, if we bring the digitalization technologies to the population that don't have the facilities, are not ready for that, it will widen the disparities or inequality, because they know I don't have that, I don't have the technology, and they will be worried about that. So in terms, they will affect their quality of life. So if used to the correct, to the appropriate population at the appropriate time, of course, it will definitely cut costs. It will be the efficient choice. But if you decided to bring it to the population that are not ready, it will widen the disparities, from my opinion. Yes, definitely. It will work both ways.
Thank you, Dr. Nawwal. We have another question. What is your opinion in regards to current condition of rich countries that also start to experience higher prevalence of NCD that would eventually affect their oral health problems? Should we still focus on poor, disadvantaged countries only?
As I give the previous example, even in the highly developed country, or even in the richest country, that would be a huge difference in terms of salary. The disparity will be as wider, because the proportion of those generating income is very minimal in compared. I mean, the salary differences are so huge that it is makes a huge difference. And to me, rich countries have their own problem, which is the inequalities. But for us, of the direction, of course, towards the even more oppressed segment of society, which is the poor and the disadvantaged. In addition to that, the minorities, the oppressed. So to me, yes, the focus is still needed to be to these developing and third world countries.
Thank you, Dr. Nawwal, for your answer. We have another question that is talking about the long-lasting effect. So the question is, what should we do to ensure that our community programs will leave a long-lasting effect or awareness to the local communities, and not just a one-touch event?
Yeah, yes, thank you for that questions. Yes, we understand that community program is not the most ideal if you do it one shot, if you do it in a touch and go kind of way. But going back to the fact that at least if we manage to empower or to teach them how to fish instead of to give them fish, but that is only able if you do it correctly. And the way to do it correctly is by not offending the community that we go in. So if we don't have enough time, one shot program, community program, of course, that is the intention, to empower at least, so that they are able to read better, have a better health literacy, have a better purchasing power, or they can decide when they were given toothpaste, they know at least which to choose, and this is particularly true for pregnant mothers. But in terms of ensuring the sustainability of a community program, let's say a national program, of course, monitorings, and again, during the early development of whatever particular program, we should take into consideration the end user, the participant who will be the main user of that program. They should be considered even before the program was developed. Then you can sort of predict at least the effect would last longer. And in terms of dental health education, of course, there is systematic review or evidence that show we need to periodically remind the community. Even us need a constant reminder. So that perhaps in the future can be done by digitalization or by the help of a better policy or a better, let's say, mass media involvement, But that would be it if it was for one shot, planning properly so that it doesn't offend, so that it will last for the name. But if it's for a longer, you definitely in the stage of development, we need to consider the end user, which is, for example, if the adolescent, we need to involve adolescent, the teachers, the guardian, before even start any nationwide program, community program.
Thank you so much, Dr. Nawwal. And thank you, Prof. Arshad, for joining this evening webinar. Would you like to discuss or ask with Dr. Nawwal?
Thank you, Lady. Thank you very much. First, my salam to Datu Ibrahim, our great legend of ICD, for arranging such beautiful seminary fortnightly 1 month. And thank you, Datu. Thank you very much. And secondly, it's a program regarding community services. And I have the few points which I will like to emphasize. First thing, digitalization is a very important task going on everywhere. Pakistan, this 20th June, going to plan that every telephone of all the companies, they will have approximately 15-second ad by oral hygiene. And that as soon as you take the telephone or any telephone rings you, you take the telephone and its first tone is that, hi lady, you have washed your teeth. Today is the 20th June. It is the oral health day. Please remember, try to wash your teeth and try to have the brush. So this is the first message we are going to display. This is a public message, and this will be displayed to all the 12 crore people of the Pakistan. And this is sponsored by 3-4 companies of the dentistry, and we have make it very sure that there should be no any name or like this. It is just a public awareness message of 15 seconds. Will be displayed to all the telephones in Pakistan, whatever any person will, like we have done in COVID, like we have done in community diseases. This is what the message we are going to deliver this 20th June, inshallah, the community. And this will be sponsored by the ICD as well, that at the will say, inshallah, okay, this message is delivered to you by the courtesy of ICD as well. So this is our one thing. Second, I will say that the problem of educated way is very less as compared to uneducated people. The thing is that our community services, we go to good companies, we go to universities, and the community which is reachable to us. But I are never focused to the community which is not reachable to us. And that is shopkeepers, that is the beggars, that is the on the selling things on the streets. And these people actually are being neglected by the community services of the oral health. And that is very important, that how to deal with these people, because it is easy to go to the school and services. It is easy to go to making the work of the dental health, and going to the community or institute. This is easy, but reaching to the this community, especially I am talking of the poor shopkeepers in the villages, and especially I am stressing up to beggars, how to deal with this community for the oral health. That is my question. Thank you.
Thank you, Prof. Arshad, and thank you for telling us that remember the effort that your country made regarding is it the landline or the smartphone, Prof? They call to remind to brush teeth. The landline, is it? So I guess that is the most common. There's still most commonly modes of communication in the residential area. To me, yes, I agree, because basically our community effort usually directed to a community that is reachable. So I guess in a way it will further widen the disparities. I guess for this marginalized group, for shopkeeper or even beggar, a more upstream approach or a more friendlier policy that can save them are required. I mean, we should advocate. I mean, it's still up to us to advocate, to direct the attention of the government on which population that needed the most. So I guess it's still up to us to encourage, another sector, all field of dentistry to into consideration. And in terms of shopkeeper, perhaps working with other agencies is required. Agencies that can reach the shopkeeper, which is the entire supply chain of products that usually the shopkeeper have access to. Perhaps we can embed a message through that, supply chain methods. And for the beggars, of course, efforts such as maybe benefits from the states can attract them to come and seek that. So taking that opportunity to also provide basic necessities, because we need to know where to look for them. And one of the way to keep them coming is, of course, when we suggest or when we offer some state benefit. So that I would personally consider that. For the shopkeeper, of course, engaging with other agency, and of course for the beggar as well, NGOs definitely another outlet that we can seek help for the homeless and for the beggars. That is
I have done
opinion.
this village, my village is Chakwal. I have done this try. Datu, it is a very joke that we have given these toothpaste and these brush to the beggars. And my few dental surgeons, they volunteered case, and they went to whole the city, and they have provided the brushes and toothpaste to them. And I was asking one of the shopkeepers, he told me, Professor Arshad, please listen to me. Today you have given paste brushes to the beggars. I said, what happened? And then they came here and sold here.
So
And they have given it that please take this brush.
yeah.
And so this is a big problem, that if you
it's
give
not entirely their fault, I guess, Prof, because that is their survival, their priority. So I guess, first of all, maybe we could take a step back and increase awareness. I don't know, increase awareness first, the fact that, even without a fully masticated, a full set of their teeth. Yeah, it's a challenge because their priority is just to survive. So oral health, definitely, it's the least of their concern. So it's up to us. So I think it's going to be a bit of a challenge.
Thank you, Prof. Arshad, for sharing, and thank you, Dr. Nawwal. We still have one more question, Dr. Nawwal, if you don't mind. The question is, what variables would you propose to be monitored for the evaluation of the success of a community program?
Okay, thank you for the question. Yes, again, it depends. It goes back to the objective of your program. If you just want to increase awareness, there should be a measurable, ideally, there should be a measurable pre and post, score, any outcomes that you can sort of say this is increased because of the program. But sometimes, from my observation, the community program or the evaluation is more of a how big or how wide is the reach of the program, which is, of course, is good. How big, how wide the coverage of a program, but the effectiveness also need to be considered. And this can only be done if you plan your program carefully and you plan what kind of measure that you need to measure. So depending on the objective of your program, it should be tailored accordingly. So if you want to raise awareness, or if you want to reduce the prevalence of caries, of course, logically, from our knowledge of cariology, it would require longer time. It will require, assessing all the factors that involve in the, development of caries. So it depends on the objectives of a specific community program. Ideally, you should have at least more than one data collection in order to have a tangible outcome measure.
Thank you so much, Dr. Nawwal. And if there are no other questions, I would like to thank again Dr. Nawwal for her.
I saw in the audience,
Yes, Prof.
somebody raised his hand. Dr. Elise, I don't know.
Oh.
Yes, actually, thank you, Prof. Thank you, Dr. Nawwal, for the talk and your Q&A answers. Thank you for that. I just want to comment on what Prof. Ibrahim said earlier about the women have more oral health problems than men. Was this self-reported, or was it what they found in the survey?
Self-reported, Dr. Elise.
Okay, how I would look at it is that although the women reported it, that they had a problem, they obviously hadn't gone to seek treatment. And I suppose the people with the greatest, who are greatest at risk, who have the most problems, are those who, oh dear, this thing is coming up, sorry, the people that are,
you can,
thank you much. Those that are from the rural community and those of the lower income group. And we must admit that, women in that community, they have to be housekeepers, they have to be the cook, they have to be the nanny, and everything else. So I think whether they are aware of it and they self-reported, or it was on examination, they actually are the ones who don't have the time. They don't have the access, in the sense they can't get the opportunity to go for treatment. So maybe our programs on a community level must sometimes be geared or skewed a bit towards this population. We in the big cities and we who are working, maybe we don't realize this, but caring for a child, it's a 24-hour job. And when you think of taking a baby or a toddler with you to a clinic, I think we'll say, never mind, forget it. So maybe that's something we should look into in our community programs for the rural population especially. Thank you.
Yes, Dr. Elise, I completely agree. To me, the availability of primary care clinic, I think, would have a better impact if we consider after office hours operation, especially to this sector of population who have a lower social capital. They don't have somebody to trust their children with. So they stay at home and just, I deal with my dental pain. So if the primary care clinic can open, a periodical alternate Saturday for this specific population, maybe utilization rate can increase, and maybe we can specific to that population on that specific day. And this is the same with orang asli or the aborigines, because they are very going from the orang asli in Pahang, they mentioned that they are a rubber tapper, or they are very agricultural population.
Shifting cultivators.
Yes, cultivators, yes. So 8 to 5 is definitely agro. So the moment they are settling with the primary clinic is closed. But if it was available weekend or half day, even Saturday, they can plan ahead and set up appointment. So at least utilization rates can increase. That would be my, perhaps we can venture into that, because the clinic is there, but accessibility is perhaps can be better. That would be my opinion.
Thank you. Thank you, Dr. Nawwal.
Can I add to what you said just now, Dr. Nawwal, about accessibility? And there's two things that I wish to highlight here. One of it is by the Malaysian government, where they do the UTC clinic, where it's open after office and also Saturday, Sunday. This is to provide accessibility. I think those who are Ministry of Health Malaysia will know about that.
Yes.
And of course, when I was at the UITM before, I introduced a Saturday clinic. Why? Because to increase accessibility, because many of our patients prefer to come on Saturday because of schooling,
Yes.
all these things. And so, yeah, giving access is one important thing that or that the initiative that have taken up by the Malaysian government to the UTC urban, even on, as I said, on Saturday, Sunday, they are working. And also, of course, the Saturday clinic, the UITM open once a month, also will facilitate this, what we call that accessibility of patients for off-office hours treatment. Thank you.
Yes, Prof, I completely agree with your, in terms of accessibility, yes. Thank you, Prof. Dato'.
Thank you, Prof. Dato', and thank you, Dr. Nawwal, for sharing with us very interesting and very important topic. And now I pass the session back to Prof. Dato' for briefing on the next coming speaker. Thank you, Prof. Dato'. The screen is yours.
Thank you very much, Dr. Nawwal, and thank you for the very informative and useful presentation you shared with our audience tonight. And I think we got about more than 140 people who have joined us tonight from what I've seen in the chat group. And recently, I hope that you can bring, of course, you can bring the things that what you're doing is something that useful for the community. People always thought preventive is not, you cannot charge for preventive or for oral hygiene is such or what, but actually preventive means a lot, because cure, preventive better than cure. You can treat the whole community, whereas in curative like mine, in restorative, you only treat one patient at a time, whereas you treat a community at a time. So the wonderful thing is to have this community service to provide oral health scrag or promotion to our patient. And thank you again on behalf of. Okay, by the way, I just want to just now the moderator when she introduced you, she said you're a PhD candidate. Actually, Dr. Nawwal has already passed his PhD recently. Thank you very much, Dr. Nawwal, again, and thank you all for listening. And then, of course, as usual, I will introduce our next speaker. Our next speaker is it's not. This is our next speaker. Is Dr. Muhammad Khan Ashif, a countryman of our Vice President.
Oh.
She is going to talk about increasing trends towards 3D cone-beam CT images analysis for dental age estimation. Dr. Muhammad Ashif, Khan Ashif is at the Shifa Tamil Mialat University of Pakistan, and join us on the 14th of June to listen to our next month ICD webinar. Again, thank you very much all for coming to listen to our webinar tonight. Thank you again to our speakers. Thank you again to all of the education team, Dr. Nagam, Dr. Amy, and also Datin Mayuna, and also Prof. Arshad, who always do not miss our webinar, monthly webinar. Thank you, and till then, we meet again on 14th of June, same time, 9:30, and on Wednesday as usual. Thank you, and have a good rest. Thank you very much.
Thank you, everyone. Assalamualaikum.
Thank you, Prof.
Thank you, Prof.
Dato'.
Arshad. Thank you, Prof. Dato'. Thank you, Dr. Nagam. Thank you, everyone.
Thank you.